here. The scenario, again, listen carefully. You can hear this in another form another time. Patient comes to the hospital. She's not having any contractions. Her membranes are ruptured. They're going to hand Pitocin. Is it induction or is it augmentation?
Augmentation.
Oh, no,
Okay.
it's induction.
It is augmentation. Labor started because her membranes were ruptured. So she spontaneously started with labor even though she's not contracting. Okay. Has everybody had an opportunity to see Pitocin running?
Yes.
All right. So we're gonna talk about the other drugs that are used, and then we'll come back to Pitocin. Sometimes when it's medically necessary to induce labor, the cervix is not right. What do I mean by right? We like that cervix when labor starts to be soft, to be thin, to be stretchy, already starting to efface, right? Because she's going to make faster progress if it's that way. But let's say she has gestational hypertension, or she has diabetes, and the baby's big enough already, and they've checked to make sure the lung temperature, and they say, this baby's going to be better delivered now than waiting. There is a chart in your book that is called the Bishop score, and I think it's around page 6. The Bishop score is a way of looking at the cervix, and don't memorize this. It's not like the APGAR. Please don't waste your little brain cells on it. It's not that important. Just know that the Bishop score is a way of looking at the cervix and thinking whether she's likely to respond to medication or not. So that if the cervix is long and thick and closed, she's not really a very inducible. That doesn't mean they can't induce her. It just means that she's not very ready for the whole process. In that case, they are likely to use a prostaglandin drug for cervical ripening. Different hospitals use different protocols. Some places use a Cytotec tablet. Some people use Prepidil or Cervidil, which is either in a syringe or with a little string attached, where it's placed in by the cervix to help ripen the cervix. And it can be removed if need be. And typically, if they're going to use a cervical ripening agent, the patient comes in the evening before induction to get that put in. So now, picture yourself. You're the nurse on labor and delivery, and you're admitting Mrs. So-and-so for induction tomorrow morning. And the first thing you're going to do, like any patient, is put her on a monitor and get a baseline, right? 20 to 30 minutes making sure baby looks good, she's not contracting, she's fine. She's had her dinner, you've oriented her to the room, and now she's got the monitor on. So you would explain to her that you're going to leave the monitor on her all night, and as she moves around, it may come off, or it may not be tracing really well, and you'll try not to wake her up because you really want her to get a good night's rest. You'd like her to go to the bathroom first before the medicine is put in, and try to stay in bed for at least 30 minutes afterwards so the medicine can be absorbed and start to do its work. So she does that. And in some states, the nurse puts the medicine in. In other states, it's the house physician or a physician's assistant or a midwife that's putting it in. Medicine is inserted, but the most important things you do before you leave that room and tuck her in for the night is to tell her when you want her to call you. When do you think you want her to call you? If her contractions are uncomfortable or painful, you want to know about it. You don't want her in there having the baby all by herself. And when else? When her water breaks. Absolutely. And many people will go into good labor during the night. They're nice and relaxed. The medicine gets the cervix soft, and they'll go into labor. And my clinical group starts the morning at 10 in the morning. And oftentimes when I come into L&D to find out what's going on, I'll see patients that came in the evening before, had Cervidil put in, and they have delivered in that time period between 6 and 10 in the morning. So sometimes all it takes is just a little bit of that medicine to get things going. In other cases, all it did was soften up the cervix a bit, and now, the next morning, they're ready to start the Pitocin. So just to go back to prostaglandin analog, what is an analog? Similar or look-alike. What's the opposite of a prostaglandin analog? Well, an antagonist, but we call it another thing. If you give a patient ibuprofen, what are you giving? A prostaglandin analog or inhibitor? Inhibitor. Okay. So ibuprofen, Anaprox, Aleve, all the big family of drugs, those are prostaglandin inhibitors. And they work for menstrual cramps because they block the sensation of the uterus contracting. Where analogs work to make the uterus contract. Although they're really for the cervical ripening. So now, everybody clear on that, or is that clear as mud? All right, it's the morning of the induction. Day shift is here, and the pharmacy sends up the bag usually, but in some smaller hospitals you might be mixing it. And usually you're putting 10 or 20 units of Pitocin in a 1,000 milliliter bag of lactated ringers. Why lactated ringers? Why not saline or dextrose with D5 and W? They don't need an extra shot of saline, and you're not going to give them dextrose in water because you don't want to get to water intoxication. So you're going to put it in lactated ringers. Oxytocin can also have an effect of diminishing urinary output. We don't usually worry about it in labor delivery. We're working with a young, healthy population that's usually between 15, 16, and early 50s. Okay, so there's the oxytocin, and you've all seen it running, and it's always run, and don't shoot me on this, because I know from Med Surg, everybody says, no, it's not piggyback, it is piggyback. It is piggyback not because it's lowered, and there's another bottle higher, it's piggybacked because it's plugged into the main IV, okay? Because it's on a pump, you don't have to raise or lower anything. Here's my question, and I'm going to ask for a show of hands, and this time your hands need to go up, okay? The question is, on an IV, when you plug into a port, there are two ports. There's one port on the IV tubing that's pretty close to the drip chamber, and there's another port that's down close to the insertion of the Jalco or the angiocath or whatever you call it, the thing that's not a needle. The one that's close to where it's usually put in, and lots of the time we're using the wrist, is called proximal, and the one that's hanging up by the IV is distal, right? Okay. So where does the piggyback Pitocin get put? Does it get put in the proximal one, or does it get put in the distal? Show of hands for distal. Show of hands for proximal. Woohoo! Woohoo over there too! It goes, yes, it goes into the one that's proximal. Okay, so about 5 of you got that right. The rest of you, learn from them. The reason why, guys, the reason why is that when you're running Pitocin and you find tumultuous contractions, or the baby starts having a deceleration, do you want to have that whole tubing with some Pitocin already put in it? No. You want to be able to shut off the Pitocin as quickly as possible. So you want the Pitocin piggyback as close to the main line as possible, so that when you stop it, the effects wear off in that 1 to 5 minutes. That doesn't mean the contractions are going to stop in 1 to 5 minutes, because her own oxytocin has probably kicked in. She may still keep right on contracting.
Is that what you're supposed to do? They don't do that.
They don't do that. The only process a liter bag of medicine is in the lactated. There is no other.
Yeah, it's just, there's no food.
Or maybe we're.
No, that's all.
I saw
You always have that hanging.
No.
Just one and it does go through a pump.
It goes through a pump, but the Pitocin is already mixed in.
Right.
It says lactated ringers. It says lactated ringers.
There's no.
So you don't have any, so when you shut off the pump, you have nothing else running in?
They just hang it in their bag.
They have to hang it in,
Yeah, they have another bag that's on the counter.
Which is why I used to question weird.
All right, that's unusual, because most every place that I've ever seen it, there is a second bag there, so that immediately when you want a hydrator for an epidural, or you want to counteract the fact that you've shut off the pit, you can run the other IV wide open.
But we see this on an exam.
If you see it on an exam, and you're asked where you plug Pitocin in, you plug it in closest to the body as possible. That's what your textbook says.
But they also always have to, they always have the plain lactated and then like that. So now you're running, you have to physically change that. You have to change out the tubing.
That's new this semester, but it's not been the case, whatever.
Yes.
Wow.
Yeah, that's weird, because I think
Okay. What's the nursing care for the patient that's got Pitocin running? What is the nursing care for the patient that's got Pitocin running? Mine?
So you have 10 units in 1,000 ml of lactated rigor. What's the time difference if it's in the proximal versus distal insertion site? And the short half-life is 1 to 5 minutes in the proximal. If it's actually in the distal and you get that much,
Then you have that whole tube to run in.
what's the time difference?
Depends on what rate you're running it at. You're starting it not with a drops per minute, but you're running it as mUs, milliunits. Okay? So, and you usually start Pitocin anywhere from 2 to 6 mUs per minute. Okay? So, again, it all depends on what the rate is at the time you shut it off as to what the time would have been or would be for that to run through. So if you're just unplugging it up at the IV with Pitocin and plugging in the lactators there, you've still got Pitocin in the IV tubing. Are you switching the tubing? I don't get it, but that's okay. Yeah. Back to the nursing care for the patient that's got Pitocin. We've always run a baseline first. So we have her on a fetal monitor. It's unlikely that once she has Pitocin running, she's going to get up and walk around very much unless your particular hospital has a walking monitor. I know Shady Grove has one. They're like telemetry, so the patient can walk with them, but they don't work well. And the reason they don't work really well is you've got a round belly and you've got straps trying to hold something in place and it slides. It slides to a smaller area, so when you stand and your belly's like this, it slides downwards or upwards, but it doesn't continue to pick up the heart rate really well. And that is uncomfortable for most healthcare providers to not know what the baby is doing while they're running Pitocin. So most people are more or less confined, not necessarily to the bed. They can still sit on the ball, they can sit in a chair at the bedside, depending on the nurse's ability or interest in helping the patient change into different positions. But there's no reason why she'd have to be in bed until she has that epidural, or unless she has it. Yes, ma'am?
Is there like a maximum amount of fluid that you can exhaust in that euro? Because I had a patient last week and she was crossing with the hanger and plus they added magnesium sulfate. But each time they include potassium,